So another wonderful day. Connections going on. Slides in place. Welcome. Welcome to another Medical Mondays with Dr. O. I'm Dr. Toyin Opesomi, a family practitioner, HIV specialist, and I treat addictions. I also have passion for medical missions, health fairs, just bridging health disparities, meeting the needs of the unmet, and also bridging the gaps even for those who have access or who should have access and are not utilizing the access they have to better their health. So here on this forum, we are, continuing in those lines just to disseminate current and congent medical information. And today, we will be continuing that with our very own Dr. Oluyemisi Famuyiwa, who will be talking about recurrent pregnancy losses that we all know, miscarriages. So, Dr. Famuyiwa, please take the baton.
Good evening, and I'm so excited to be here. I'm trying to adjust my screen a little bit. Thank you so much for inviting me. It's been a minute, so I miss everybody. So please bear with me. I have been given a series of talks where I try to elucidate the biology behind a lot of the things that we do in infertility. And Dr. Opesomi will help me break it down sometimes for you. So we've been through a series of talks on the basics of implantation, pregnancy, and now I'm going to talk about pregnancy loss, but I'm not even going to cover the full scope. I'm going to try and shed some light on some of the new fascinating discoveries being made in the field of recurrent pregnancy loss. So a lot is happening in that field, a lot of new technologies and treatments coming out. So that's what I want to shed some light on. Anyway, so today's topic is going to be on recurrent pregnancy loss. Let me go to the next slide here. Oh, how do I do that? I'm going to ask for your help here. How do I'm trying to, I've already turned it on my.
So you can do the, how do you call it? When they say, the slideshow.
Okay.
If you have the slideshow on.
Resume slideshow.
Yes. Okay. That way you just, there you go.
Yes, okay.
For the arrows, yeah.
All right, so I'm going to start with trying to define what is recurrent pregnancy loss. Recurrent pregnancy loss or recurrent miscarriages, which is the lay term or the medical term, is recurrent spontaneous abortions, occurs probably in about 1 to 2% of women. Now, how many percentage of women actually have miscarriages? Identified miscarriages occur in 15% of women. When I put in there recognized, that means that a lot of women who actually have miscarriages are not even aware that they have a miscarriage. They simply may not even recognize. They may say, oh, you know what, my menstrual cycle was a week late or was a little bit heavier than normal, or they may not even recognize that they had implantation. So if you look at all pregnancies, probably about a quarter or slightly more is actually aborted. So human, which I think I've tried to express in this forum, is human gestation is not very efficient. What causes a pregnancy loss? So before we go into why does it happen over and over and over again in some women, I know there's one of the stars that came out today and said she actually had 9 losses and nobody knew about it. So they put on a brave face, they go on with their business, but it happens. So common causes that we know of include chromosomal abnormalities. Now, before I go into additional losses, additional causes, one of the things that happens is when someone has had a pregnancy loss, it increases their risk of having a subsequent loss. So if they've had one loss, that risk goes up to 20% in the subsequent pregnancy, all the way up to 43% after 3 losses. Turn my slide here. Oh, that's not working.
Does he have the arrow? There you go.
There you go.
You see the arrow?
Yeah, it's not working for me. I think because I have 2 screens. Oh yeah, you can see the arrow there. Other causes include genetic causes. And when I say genetic here, I'm not actually talking about the embryonic cause. The most common factor when someone has a miscarriage is actually an abnormality within the DNA of the embryo itself. Now, if you go about several courses or talks that I gave here, I think I had shown before how the egg and the sperm actually, how the egg is fertilized, and the DNA of the egg and the DNA of the sperm has to match and exchange genetic information before you have further cell division. Well, that match is not perfect. Some things get dropped, some things get added, and you end up with what I call a genetic accident. The medical term is aneuploidy. So that's the most common cause. Now, other causes include genetic causes in the parents. So if the parents are either missing an extra DNA, or they have missing or have additional DNA, they may get what is called a translocation in the baby, and that can result in an abnormality that is not compatible with life. So that would fall under genetic causes. Other causes will be anatomic, such as someone having a septum that prevents proper implantation of the embryo, or they have an abnormally positioned fibroid, such as in the cavity. Other causes will be endocrine causes. If someone has thyroid problems, for instance, or they have diabetes. Autoimmune causes will be things like lupus, or they have the so-called antiphospholipid antibody syndrome. And then the vast majority are simply unexplained. All right. So what are the risk factors that may predispose someone to a recurrent pregnancy loss? Things such as thrombophilia, those are patients who have abnormalities in their blood. Antiphospholipid syndrome is when somebody produces antibodies that can attack the baby. Extremes of weight loss, so someone who is lean, has a BMI of less than 15, may have, if they have a BMI of say less than 25, right? They may have a risk of pregnancy loss of 14%. Extremely overweight women may have a risk of loss of 42%. So weight is very important. Patients who have high blood pressure that's uncontrolled. So someone who has recurrent losses, you need to do a complete history and physical. If they're hypertensive, that needs to be controlled. Cigarette smoking is not very good for pregnancy. So some people may miscarry if they're heavy cigarette smokers. Large amounts of caffeine, excessive caffeine use, can also increase the risk of recurrent loss. Trauma, you can imagine would cause it. Malnutrition, and have to be severe malnutrition will cause that. Change that. And I think I already gave the juice away on this one, talking about miscarriage rate by BMI. So you can see someone, if someone is having really repeated losses and they're moderately obese, it might be a good incentive to help them work with trying to lose that weight. And if they can't do it through diet modification, I usually tell them to seek a physician weight loss program that might help them. Now, before I go on, I want to show you guys a movie. As you guys know, I love movies. So I'm going to show you a movie of an embryo implanting. Unfortunately, I didn't have time to show the anatomy of the uterus. As we all know, move that there, yeah. The egg, when it comes out of the ovary, gets picked up by the fallopian tube. It is fertilized inside the tube, and then the tube has this hair-like structure that moves like a conveyor belt that moves the embryo to the cavity. And it actually takes 5 to 6 days to get to the cavity. And while it's on that journey, it's dividing rapidly. By the time it gets to the cavity, it becomes what we call a blastocyst. When it gets to the cavity, there should be a conducive environment for it. Factors must come in place that allow the embryo to be implanted, meaning that the mother's uterus must accept the baby. The baby must be ready to be accepted. So there's like crosstalk that leads to implantation. So let's see if my little movie will play. You can see an embryo arriving in the uterus, and there are factors that come into place, and that embryo is subsumed into the cavity. And at the end of it, you see a little dimple where it was absorbed into the cavity. Now, what happens here? Okay, in the initial part of implantation, there's an inflammatory process that has to take place. Natural killer cells are involved, immune cells are involved, that allows a sort of initial inflammation to allow this embryo to tunnel through. Okay, see how it, and then you have the syncytial trophoblast, the blastocyst cells here, or placental cells here, that are tunneling their way in and implanting. While they are implanting, this embryo is a foreign body. It's like an allograft, right? There must be other crosstalk within the mother's uterus that prevents her from saying, oh, you know what? This is a foreign body, spit it out, not accepted, right? So there, and then when that initial inflammation occurs, there should be another subsequent dampening of that inflammatory process. So first you need inflammation to get in, then you got to quickly shut it down, because if you keep it inflamed, it's going to spit out, okay? And there are several factors involved in the crosstalk here. A lot is now known, well, being studied about what happens at this level. It's so critical. It involves immune cells from the mother. It involves the sperm as it traverses the cervix. It triggers a set of recognition of natural killer cells are triggered that starts to encourage the mother's immune cells to respond. And then there's another crosstalk that tells this immune cells to turn off. Now, one of the things that you might see is that we'll talk a little bit about what therapy is being proposed, trying to manipulate this critical phase and trying to keep that embryo where it should be. All right, so let's go to my next slide here. slideshow. Okay, hold on. There we go. So I talked a little bit about what happens at the level of the uterus that allows the embryo to escape being destroyed by the maternal immune cells. This whole complex dance, symphony, ballet can be disrupted in certain patients where you have what is called natural killer cells. There are different types. There are some that is low that you see in the peripheral blood. These are different from the ones that actually exist within the cavity of the uterus itself. And these are also separate from the ones that you may see in the vagina and the lower part of the cervix, right? So when you measure, and I know there are some places where they tell you, oh, yeah, just go for a natural killer cell assay in your blood. It is not measuring what's going on in the uterus because there are different kinds of natural killer cells available. All right, so let's go to the next slide. Aha. Now, how can you sort of try to treat this? So a lot of this is being worked out by reproductive immunologists. Those are subsets of infertility doctors that choose to sort of investigate this really complex and exciting field. What are the things we can use? Now, remember that recurrent spontaneous loss related to immune factors is very, very, very rare, right? So it's not a common thing, right, that we're looking at. The vast majority will still be at the embryonic level. And again, I go back to some of the talks I gave before on how we can test the embryos to make sure they are normal, right? Oh, before I go, just a little analogy, right? When you have a pregnancy loss, there are two things that happen. A, the uterus recognizes an abnormal embryo and said, no, not allowed, right? That's what's supposed to happen. It's supposed to be a gatekeeper, right? Or the embryo gets there and it's normal, but then there are factors that are not conducive to accepting the embryo. How can you treat it? One of the things we commonly use is aspirin. If it's not contraindicated, someone doesn't have an ulcer or something like that, it may be used, minimal side effects and probably beneficial, especially if you have elevated CRP levels. Progesterone is usually one of the things we use a lot of, especially right after ovulation, because again, minimal side effects and effective in a subset of population. So it's readily available and beneficial for some patients. Now, the rest of the therapy is not what you would go to on a routine basis, such as low molecular weight heparin. There are some people that propose that the reason you have a pregnancy loss is if you form small clots underneath the placenta, such that in a hypercoagulable state, and you form microclots, there's not enough exchange of material between the developing baby and mom, and you can easily have a loss. So heparin, low molecular weight heparin, has some beneficial effects. And it also has some properties that enhance the growth of new blood vessels, which, as you can imagine, is important for proper placentation. Steroids may be used in certain cases, but you have to make sure the patient is not diabetic, not hypertensive, may be beneficial in someone who has losses maybe around the later part of the first trimester, and probably has to be in a program where a physician who's familiar with it is monitoring the use. Now, we're going into some of the more newer tech things out there. And also some of these are more experimental, so don't expect to see it mainstay. You will get them mostly within a clinical, like a clinical research setting. One of the medications being used is called tacrolimus. It's an immunosuppressive medication that is used to prevent organ transplants. It does have side effects, as you can imagine, and I listed some of them there. One of the things, what does it do? It tries to reduce the mother's immune response beyond the time of implantation so that the mother's immune response does not continue and proliferate and shift to a highly inflammatory state where the pregnancy is lost. You try to start it 2 days before you might, say, transfer an embryo in an IVF cycle and continue it on for like 16 days. That should say pilot study. And there are initial studies that are showing increased pregnancy with it. I jumped that one. Increased pregnancy and live birth with the tacrolimus. I think I skipped a slide there. Other things that are sometimes used, again, should be used in more of a clinical research setting. There are centers that use it successfully, but they have carefully selected the patients that they choose to give this medication to. It's intravenous immunoglobulin. As you can imagine, it's expensive and it has to be monitored. But the studies are still inconclusive. There are some patients that have shown some benefit from it. You know, as they say in the news, it's not ready for prime time because it's still being, they're looking at randomized clinical trials. Other things that may be used, and this skipped a slide here. Tumor necrosis alpha inhibitors. Okay, let's go to that. More experimental things being used. Now, the mechanism of action of this one, a TNF alpha, it's one of the newer medications coming out there that inhibits the Th1 immune response in the human body. This Th1 has been shown to be very active in patients that may have, say, arthritis, plaque psoriasis, severe asthma or atopic dermatitis, Crohn's disease, ulcerative disease. So it's a medication that's been investigated in all these immune-related diseases. And then people say, well, why, if we think that there's a subset of patients that have recurrent loss because of immune-related etiology, maybe we can now use the same medication in these subset of patients. So again, the studies are preliminary, but the idea is to reduce inflammation. Here, change this slide. Other things include intrauterine PBMC therapy. This is obtained from the mother cells. They're cleaned up in the presence of albumin and then instilled back into the uterus in a catheter. Again, experimental. The theory behind it is to, again, reduce the Th1 inflammatory pathway. Another thing that I did not have time to put in a slide is you might hear about intralipids being infused in certain patients. Intralipids are basically things like fatty acids or lipids such as soybean oil, olive oil, fish oil, some with medium chain fatty acids, and infused. Experimental, the mechanism of action again is to reduce inflammation, especially along the Th1 pathway. It's being used in research settings, university settings, where they have a controlled randomized trials. And I think that's where it belongs to. But I think one of the things that I got from preparing all this is, you see, if you have a chronically inflamed metabolism, chronically inflamed state of being, there are other diseases besides Crohn's, diabetes, heart problems. It can affect pregnancy. It lends more credence to what we've been talking about in this forum, is to try to maintain a lifestyle that reduces inflammation, such as plant-based diet, or if you're going to eat more fish that has, like, I like to eat my fish oil and in fish such as salmon, and not necessarily in a pill. Anyway, so thank you so much. This is the end of my talk, and I'm going to close this and ask for questions. Yes, sir.
Thank you so much for that presentation. I don't know if the non-medical folks on the forum would appreciate what you put together there so succinctly for us. It's huge, it's a lot. And by God's grace, as we dialogue now, we will break it down more. But pregnancy losses are some things that are very traumatic. It is important that we discuss this subject, and to discuss also Roe versus Wade, because this all ties in. We are non-political on this platform. This is medical, and so get ready for that discussion tonight, because we will touch it, we will get there. Did you say somebody had a question?
Yes, Dr. O, I did have a question.
Oh, go ahead, Dr. Craig.
Good evening, Dr. Famuyiwa.
Good evening.
I have a couple, it was rare, young women who were end-stage renal disease, kidney disease, on dialysis, who became pregnant. And we had to, well, it was just a very special cases in that we had to caution that they had to be dialyzed every day.
Ooh, wow.
For the 9-month period of pregnancy. And even then, I believe that they had early term, they came to early term in some cases. But fortunately, the babies that were born were at first, normal. There was no adverse anything noticed per se. We never tracked it. We never managed to track what was going on. But the dialysis every day for these young women, we're talking about 3-4 hours of treatment, was really extraordinary. And some of them were able to do it. I'd say 90% were able to do it. But I'm curious, how does dialysis impact the process of pregnancy, and can we be certain that there is no adverse event with the baby that is born?
Definitely, I don't think we would be taking an end-stage renal patient through the process of IVF. As you can imagine, that could be extremely deleterious to their health. But once they're pregnant, that has to be managed with a maternal fetal specialist on board. And that is a specialist that deals with high-risk pregnancy, because you can imagine most of that pregnancy will be spent maybe antepartum in the hospital, because anything could go wrong. It's a very delicate situation. I unfortunately do not manage high-risk pregnancy. I usually hand over my patients once they hit 7, 8 weeks of pregnancy, but that would be a very difficult case. It's one of the reasons why some people who have end-stage renal failure may be advised to consider pregnancy using, a surrogate or an egg donor, for instance, because you don't want to put them through that.
Understood. They were outpatient, incidentally. They were not inpatient.
Incredible.
So again, it was a kind of a miracle that she was able to even.
Right. So I bet they had a maternal fetal specialist on board throughout the whole thing.
Okay, thank you.
Thank you so much for that. I've never seen a pregnant woman who has end-stage renal disease. Now I'm curious. You've awoken my curiosity to do some reading, some research.
Yeah, it's one of the reasons why, when people are saying, if they have active lupus, that's a contraindication for pregnancy right there. I had a patient that we were going to do IVF on, and she came down with severe lupus, and we had to stop, and she's still in a very active state. And I told her the most important thing at this point in time is her health, right? Her health.
Well, the thing is, the patients you talked about, Dr. Craig, I bet you they were natural pregnancies.
Correct.
And this does happen.
Yeah.
So yes, they will be outpatient, but getting dialyzed every day.
That's a lot.
That's amazing, incredible. I mean, it's, whew. So thank you for sharing that. I learned something new. Sister Tower, kindly unmute and ask your question.
Good evening, everyone. Good evening. I'm just wondering, there are people with multiple fibroids. How do you handle that if they come for IVF?
So that's a whole different lecture.
And multiple is a lot.
And we've actually talked about that. And I think I'm on my next webinar, I've talked about inviting one of my a GYN oncologist that deals with the complicated surgery. It depends on location. Where's the fibroid? How big? How many? Have they been operated on before? How many scar tissue they have? So a lot of times you can get away with getting them pregnant. Depends on where the fibroid is. But unfortunately, I have seen a lot of tragic cases where the uterus is completely riddled and overrun with fibroids. There's no normal ovarian uterine tissue left. And some of these patients may have had recurrent surgery, repeated surgery. Unfortunately, there's not much you can do for them. You really can't. There's nothing you can do for them.
Thank you.
Mm-hmm.
Well, when they have scar tissue, the area to implant becomes kind of limited, right?
Yeah, it's not only just implantation, but well, implantation for sure. But if they have a lot of scar tissue, they just don't. The pregnancy just doesn't go well, and in certain patients, you might have adenomyosis, for instance, or you have a lot of scarring. It's very difficult to sustain a pregnancy to fruition.
Wow.
But yeah, so fibroids, I usually like to get to them before they become really, really bad. And another thing I always recommend is if the fibroids have been removed, usually wait 4 or 5 months, 6 months, and start actively trying to get the person pregnant. Now, if they get pregnant on their own, more power to them. But if they don't, sort of kind of move it along, because I have seen cases where they wait and they wait and they wait, and a year later, the fibroids, obviously it's not the same fibroid, it's back, it's worse, and they need additional surgery. And then by the time they go for the second, the third surgery, the fourth, what's left is really not, it's just a scarred mass of tissue. And it's very, very heartbreaking because a lot of these patients just don't get it. You can't convince them that there's nothing more you can do. And that's the tragedy.
Thank you. Thank you so much. Dr. Ajagbe, you have your hand raised. Unmute, sir.
Okay. Dr. Famuyiwa, one of the things that is most common that you didn't mention, I'm sure probably because it's not on the forefront, is gum disease.
Crohn's?
Gums.
Oh, gums. Okay.
Periodontal disease.
Oh, yeah.
Gingivitis.
Right.
Gingivitis, periodontitis, and all that.
Right. So that goes into the overall general health of the woman, right? Because again, probably an excessively inflamed state.
No, actually, that has been studied very extensively.
Yeah.
In 1996 was the first article published that tied, chronic periodontitis in pregnant women to very negative pregnancy outcomes, including miscarriages, including low birth weight and stillbirths. And in fact, there was around 2005, there was a big case of the population in the Washington, D.C., and the District of Columbia, the minority women. It was kind of like a crisis that there was a very high level of low birth weights and early childhood death, among the African-American population in Washington, D.C. So one of the things that I think is imperative to, particularly for those who have experienced one or two miscarriages, is also to check their mouth. If they haven't been going for dental checkup, it's imperative because there is a direct correlation between the bacteria in the mouth and the direct effect on the implantation or the lack of it.
Thank you so much, Dr. Jagbe. You know what? Amazing points. I mean, right on point, because we do send pregnant women to dentists. So everyone on the forum now knows, especially women, why their doctors recommend that they go see dentists. Oral health has been linked to heart problems, pregnancy issues. It's very important that we take care of the oral health. Flossing at least once a day, at night, right, Dr. Jagwe? Because the bacteria would colonize the mouth while, in sleep when you are not talking, and they do their evil. So it's important to floss and to brush, not just in the mornings, but at night, generally. But
and more so because women, when they are pregnant, they have cravings, and many of them crave sweet stuff. Mm-hmm. And when they crave chocolate, they crave ice cream, they crave so many sweet things, and they don't take care of their mouth afterwards, gingivitis and periodontitis will become rife, and it will affect not just them, but their own children. Now, the other side of that is that many of them lose their teeth prematurely because of chronic periodontitis. And once they do, they are unable to eat well. So it's a vicious cycle. They lose their teeth prematurely, they can't masticate their food, then the babies don't get enough nutrients that they need to develop, and it's kind of a continuous vicious cycle that goes on.
Thank you so much. Thanks for that input. Dr. Craig, you have your hand raised.
Yes, another question. And I was sent some patients over the years who had a propensity to actually develop fibroids, frequent fibroids. And the thought was that there was a nutritional imbalance. So, they were sent to me and with extensive lipid profiles that were done over periods of time. Have you associated any of that in terms of fibroid use and people who have abnormal lipid profiles in patients at all?
Well, there's some theory that low levels of vitamin D may be etiologic in some patients. Incidentally, low vitamin D may also be associated with recurrent pregnancy loss. So, definitely you want to replete your vitamin D levels for sure. Data is not that strong, but again, it probably just goes with making sure you have an overall healthy diet.
Dr. Ajabe mentioned the low birth weight a thing going on in DC. That was years ago, and I was part of that panel in terms of the March of Dimes were the ones who were actually pushing it through, because there was an extensive, as Dr. Ajabe said, happening with women of color and low birth weight. And it was believed that, in addition to many things, it was about their ability to access proper diets, proper treatment, and along different avenues of that. Many years ago, I don't know, how we kept on moving forward with it, but it was a significant incident in the DC area and in Washington.
Yeah, and then a lot of that is also multifactorial. And part of that too, that we talked about related to recurrent pregnancy loss is malnutrition and extremes of weight, either too low or excessively high, can be etiologic in the two different disease processes we are talking about.
There's a doctor in DC, a Dr. June Cress-Welsing. I don't know if you ladies are familiar with her. Are you familiar with her? Who did an extensive study on vitamin D and melanin. And her study was actually extraordinary, where she pointed out that many of the factors which are being seen, as you just stated, were pointing to low D status at this point. And I'll even say now, in this present day, many physicians are now measuring D as part of their management, patient management, and employing D. I know for certain in the renal community, it is now a major factor because it involves the bone condition, as you know, of course, and it's critical to make sure that that level is maintained. So it's going on right now.
Well, vitamin D level is also one of the things that is part of the fertility workup. So we always evaluate the vitamin D level for patients who are infertility patients. So we definitely evaluate the vitamin D levels when we have a new patient who's an infertility patient. That's one of the things that we always measure.
Do you associate a low calcium also with a low vitamin D in terms of and hence the immune system being impacted at that level?
We don't really look at the calcium level. I think it's the vitamin D level more so that we evaluate. So we usually start with that first.
Yes, and Dr. Famuyiwa is right on point. We actually don't recommend that people take calcium supplement routinely. We encourage vitamin D, and there's still a lot of research going on vitamin D. We've talked extensively about vitamin D on this forum at one point last year. And we've discussed the fact that vitamin D, when it's low, when that means you're deficient, causes high blood pressure, multiple sclerosis, osteoporosis, which is a bone disease that makes the bone brittle, and people can have fracture without injury, without falling or having any kind of trauma. It causes constipation and low back pain. It's been linked to dementia, depression, and colon cancer. So now we see also that it's linked to pregnancy losses. So researches are still going on vitamin D. I think Johns Hopkins and Mayo, I can't remember exactly, but you know, some big institutions are still studying about vitamin D, but we don't recommend routine calcium intake. In fact, nephrologists would go crazy if they see that one is taking calcium without actually needing it. And it's important to check the levels of vitamin D because too much of it can become toxic. So yes, Dr. Craig is right that a lot of us are now checking those levels routinely. So that's one point. I have a question for you. You talked about, you know, we know about obesity causing problem everywhere. Overweight, obesity, it's a disease now, and it causes a lot of issues. But you talked about lean mass, that is somebody who is lean, can also cause like 14%.
Well, actually, so that 14% is just general background noise, right? That's what you see in the general population, right? So that 14%, in some literature they say 12%. Yeah, I'd say 10 to 15% is what you will see as recognizable pregnancy loss. So that's background noise. Against that background noise, increased weight now causes higher levels of miscarriage. Oh, incidentally, fun fact, you want to know who has one of the highest miscarriage levels?
What, do you want me to guess?
Go ahead. If
Black
you can, that's
people?
fine. Doctors.
Black people? Doctors.
Female doctors.
Okay.
So if the general population
Oof.
miscarriage rate is 1 in 8,
Mhm.
for physicians, doctors have a higher rate, 24, 30 some percent. And they also have a higher incidence of infertility, right? Infertility in the general population is 1 in 8 women. In physicians, it's 1 in 4, right? And out of the physicians, surgical specialties have the highest rate.
Okay,
Specifically
now,
orthopedic surgeons.
why is that? Because you know what? I had 3 miscarriages.
Yes.
I praise God for the number of children I have, but
Yeah.
I still, in everything in life, it's one thing that I still feel, geez, wish I have more.
So
I'm grateful for what I have. Don't get me wrong, wonderful children, I love my children.
Well,
but I wanted a quiver full of them.
So yes, you're in good company because doctors have the highest miscarriage rate and infertility rates.
Wow.
And that's one will be my next blog topic. I think if you have a medical school student as a relative, you should gift them a voucher for egg freezing as their graduation gift. Don't buy them anything else.
Okay.
Give them egg freezing voucher. That's what they need.
It.
Right.
That's it. Going forward, I got my gifts then. So do we know why this is the case?
Well, several factors. Number one, they're graduating and going into subspecialties at the peak fertility period, right? So you're graduating med school in your 20s and you're going right into a residency program. And some of the surgical specialties have extremely long hours where they're standing. look at orthopedic surgery. They're operating for long hours, right? And then part of it also is, sad to say, but the medical community is not very supportive of female doctors, right? So, some hospitals don't even give them a facility where they can breastfeed if they want. I was lucky that I was in Holy Cross, which is a very big maternal hospital, and I chose to breastfeed my daughter, and they actually had a very peaceful, nice breastfeeding room where you could do it. Some places don't give that. Also, a lot of times they don't give them time off, and if they take time off to get to have a child, they're made to pay back that time and then some. So it's tough for them.
Wow.
Yeah.
So that's good. Those are the places we need to look at to change.
Right. Yes.
When I was in
I
residency,
think so. I think that female doctors, we have to take care of our own as well. It's very hard to get pregnant, to deliver, to nurture your child. It's difficult. It's difficult.
See, doctors are not supposed to be humans.
Exactly.
I was going to say, when I was in residency, our calls were 3 straight days. You do 36 hours when you're on call before you go home. That has changed now. So this will change, and we need to move for the change.
Exactly.
It's important that we know the stressors. Sometimes these things are oversight. Doctors are, doctors are cut out differently. We leave the scripture, loving people as ourselves. Unfortunately, sometimes more than ourselves.
Right.
Scripture did not teach us to do that. But doctors do that a lot. It's about patient. You don't take time to eat. You don't take time to do anything else. You're telling the patient to exercise, but you are not making room
You're
to
not
exercise
doing that.
because you don't have
You
time.
tell the patients to hydrate, but you barely get, I think Dr. O and I discussed this. I always have like 2 water flasks on my desk at all times. And I'm very blessed. My kids are always on my case. Like, what did you eat? Do you call that food? Or they'll get me a salad or something like that. So.
And you call me to remind me to drink. Getting each other's backs.
I think so. I think it's a sisterhood that we have to take care of each other, but it's very hard. It's very hard to have your child and raise your child and be there for your child. So I am very, very blessed, that my mother was with me for 9 years. I certainly couldn't have done what I did without my mother.
What a blessing.
Yeah.
So we have our advocate here, Attorney Tinu Akinshola. She already put it there. She will be our advocate. I'm going to call her. We're going to map out the steps where we can approach this so that we can see changes for the upcoming female physicians. Change will occur. It will. Dr. Jagwe, you have your hand.
Excuse me, Dr. O.
Just 1 minute. Dr. Jagwe raised his hand before you. I'll call on you next. I'll call on you. Thank you. Dr. Jagwe, go ahead.
Yeah, when you mentioned the high incidence of, poor pregnancy outcomes in physicians,
right.
Female physicians, the younger ones, you have to remember that the stress of going through medical school, number one, and going to residency, think about what is going on while they're waiting to match. Look at the stress level. And my recommendation would be like, they should be measuring their cortisol level at that point to know how many of them will become very susceptible to some of these difficult outcomes. Because even though we may smile, we may think, wow, yeah, that's for real, but it's reality for those people because what you're saying is life-changing. If they can't get pregnant and they want children, it's going to break their heart, regardless of how many, how successful they may be in their profession. And these are some of the things that we have to become holistic in our, outlook, in the way we look at everything that we do. Are these people really faring? If the medical schools don't care about them, the residencies definitely don't care about them in terms of their welfare. When a resident doesn't have enough sleep, we know what sleep does to the brain. And then the brain is the center where all these chemicals are being released. And so all the stressors are there. And it's going to affect the uterus. It's going to affect everything that pertains to pregnancy and, everything like that. So I don't think it should surprise us that is going on, because the stressors are there staring us in the face. But because the preference is to be successful, yay, I got a match. I got matched. Oh, yay, celebration. Well, you got matched, but what's going to happen in the next 4 years? We don't know that.
And that's why I say the ideal medical school graduation gift should be egg freezing. But I think that there's more being written about it, so people are becoming more aware of it. And I just realized that it really does take that proverbial village. It's not just the doctor. That doctor has family, has friends, and we all, look out for each other, and we have to. So if you have a friend who's a physician and you see that they're doing poorly, pick up the phone. Hi, how are you doing? Have you gone to get your pap smear? Have you gone to get your colonoscopy? We have to live in that village where we look after each other. So yes, we are taking care of patients because that's what we do, and most females to begin with, you're the caretaker for the family. But then in this case, you take over your patients as part of that family, and you feel responsible for them. You feel like you are their caretaker. But you do have to kind of look in the mirror and say, you know what, you have to, patients can be, demanding, right? But you have to take care of yourself, because some patients are very kind and they realize you're not a robot. And if you're feeling poorly, they say, hey, Dr. Yemi, you know what? It's okay. I understand. I can come another day. You're not feeling well, but not everybody cares. Some people say, what? You're not feeling well? I'm out of here. Call that other doctor down the road. Right? So you have to also realize your doctor's a human, living, breathing person who cares about you.
So in summary, we should just say doctors are people too.
Correct.
For those advocates, doctors are people too, so do the campaign.
Yes, right.
Hello.
Thank you so
Hello.
much. Sister Lola. Hello, sir. Sir.
Yep. Hello.
Yes,
sir. I have Sister Lola raise her hand. I'm coming to revert back to you, sir.
It's okay. Okay.
So you can give us the naturopathic aspect and the content, experience. I mean, of every one of us on this forum, I call him Papa Mike, but Brother Mike to the rest of you. Dr. Mike Oye has so much experience that I can't wait to hear what he would have to tell us. But Sister Lola, kindly unmute.
Yes, I just did.
Okay, thank you.
Thank you, Dr. Yemi. It's eye-opening for all this information. I'm just curious, and I'm not trying to do any comparison. I would like to know the next profession on the line after the doctors for this kind of challenges, because
I don't know the answer to that. I just happen to take a particular interest in this topic because I do have a fair amount of doctors in my practice, all the way from medical students to residents to practicing doctors. And it's just something that I happen to have an interest in, because I've been there. I've been there. I've felt their pain. I know what they're going through from both ends. So it's just something that touches me on a deeper level, is why I developed that interest.
Yeah, you're so right, because I witnessed a partner of mine. We're working for a store long time ago, and the call came in. The guy has to run. The pharmacist has to run to the hospital because his wife is in labor. And we had a patient, a customer that come into the store. I'm like, I'm not letting you go until you give me my prescription. You can't go. And it become a big issue. And I'm just wondering if doctors are going through that and pharmacists are going through what we're going through.
I'll share with you. I had a miscarriage, and I went to get an ultrasound that confirmed there was no heartbeat. And I also had a full office load of patients, and patients, were like, where is she? And, you put on a good face, and you go right back in there and you go take care of your patients, because that's what they want. And and you're going through your own loss as well, and trying to process that loss. So, and I don't say I find it easy to empathize with patients, but I sort of know what I went through. So if I have a patient who's going through the same, I share with them some of the coping mechanisms that I use to heal. I don't think you can ever say that anyone heals from a pregnancy loss, because that's your child that you lost, right? That's a child. True. So, I'll always say, gee, you know what? My child would have been such and such an age, or, wow, I wonder what my child would have looked like, and her whole, there's a gap between my kids, and there's the gap there. So you always think about it, and you try to process it and understand that patients are going through that as well. All right. And you try to share with them. I don't have all the answers. I don't claim to, but try to share with them some of the coping mechanisms. I mean, I certainly don't advise anyone to say, have a miscarriage, go right back to work, is not something I would advocate. But that's another thing in the papers that I was looking at. A lot of doctors who have miscarriages are not even allowed the time to take off, to recover, to heal, to process. So yeah, I totally understand, and I get it, and I don't make light of it, and it's hard. I understand.
Okay, and before I get off, I did some studies last year too. I took some courses, and sorry to say, the list, I mean, the list that came up, most doctors become like number one on the list of people that commit suicide for some reason.
Yeah.
I don't know if anybody knows.
That one is not limited to female physician. The miscarriage rate and fertility rate I was looking at was actually looking at studies that focus mostly on female doctors. Yes, there's a higher suicide rate, but then in other specialties, in certain specialties, and other stressors, anesthesia is one of them. And that's one of the reasons why you really shouldn't push your kids to go to medical school unless they want to, right? If they want it and it's their calling, then they will likely do well or cope better, because they're going to be stressed. It's going to be stressful. It's not going to be easy, right? But if you like it and you're doing it because you want to, you will probably come out the other end. But if you're doing it because mommy or daddy expects me to be a doctor, because Uncle Joe was a doctor and Auntie So was a doctor, and my grandpa opened the first village clinic, and so I have to continue this chain and on and on and on, that's not good. Because I've seen train wrecks, absolute train wrecks of physicians who, at the end of the day, were pushed in, right? I've seen train wrecks. So, and I think medical schools now are looking at trying to weed out who really was pushed there versus who genuinely wants to be there. It's a calling. It's a calling. You either are called to do it or you are not, right? No one can say you need to be. You have to love it. You have to live, breathe, love it. It's part of what you do, right? You you're fascinated or you fall in love with a human body. That's what it is. It's a love affair, right? You're in love with a human body, albeit you might pick a different part of that body to fall in love with. But you really, if you don't love the human body, you really have no business in medicine.
Well, Sister Lola, it is true.
Very true.
The the profession that commits suicide the most is physicians. We talked about that. Dr. Aluya brought that up when we were talking about mental health. And guess what? The number one specialty is psychiatry.
Wow.
Then anesthesiology and community health physicians. Who are the community health physicians? The primary care physicians are the ones that commit suicide the most.
Wow.
So I think, yes, one of it may be people who didn't have a passion or push through it, but I believe it's beyond that. It's totally beyond that. I had an attending when I was doing residency in Texas who was phenomenal, just brilliant. But he hated medicine. His parents told him to do medicine. He was Caucasian. He loved finance. And when I was in residency, when it was an OBGYN. OBGYN is a difficult residency to get into. It was an OBGYN and he had no passion, nothing for it. So anytime I was on call with him, I worked all night. I just go to him to tell him, okay, then the woman has dilated 10 centimeters, time to deliver. I go deliver the baby. Come back to tell him, hey, thumbs up, we did this. He will give me an eye. No, thank you, nothing. But, because, and he was miserable, sad. So he was studying to become a finance person. He was actually doing that. That's what he did on call. So, I don't think he will commit suicide. I think he will change profession. I don't know what happened to him, but it is what it is. There's a lot of stresses, a lot of stressors in medicine. There's no amount of money that can be paid anyone to live the life of a physician. It's not the easiest thing. I mean, you yourself, like Dr. Famuyiwa said, you have a loss or you have things going on with you, but you have to hold back and listen to your patients and meet them at their points of needs without showing what you are going through. A lot of people say doctors are the worst patients. It's because they don't have time to even give time for themselves. So, but to your other question, Sister Tinu Akinshola, she's a lawyer, by the way, she's an attorney. She said the second profession where you see high infertility and pregnancy losses is lawyers. Sister Tawa Durojaye said it's nurses. I heard, one wrote in the chat box, I heard the other one say it. So we don't know. I think we need to look it up. And you can look it up, Sister Lola, and feed back to us next week.
Actually, there's an article that was published in the Journal of Epidemiology in 1996 that actually compared maternal profession and pregnancy outcome. So if you want to look at the longitudinal studies, you must start from that and be able to see all the different, because I don't think it's static. I think it's dynamic. It's changing depending on what is hitting each profession at different times. So the ones that we know very clearly are the doctors, because of what the experience of the physicians on the panel, on the forum. Other than that, things are changing. There was a time that...
Actually, no, sir. It's been constant. Please go and Google.
I'm telling you that there's some areas that stays the same because the professions haven't changed much. But the details are constantly changing. You'll be surprised.
Yeah, Dr. Ajagbe, I think it's because they have not measured other profession. As a woman, unless you're a housewife, combining any other profession with your role as a mother and as a wife, as the chauffeur, as the chef, as the medical doctor is very stressful. But, doctors are probably the most high-paying profession, and the engineers in the female demographics, that is measured. But others, some of us are going through equal, if not more, levels of stress as women, and the hats that we're supposed to wear. Thank you.
And thank you so much, Madam CEO. You wear the same hat as us doctors. You are in medical profession, and oh my gosh, I cannot fathom all that you do in 24 hours. But guess what? Some of us, like you, have the grace to handle things, to be able to compartmentalize, and some don't. It's those who don't that I encourage us, all of us, to be each other's blind spots, so that when we see that somebody is not behaving the way they used to behave, or something is lacking, that we go after them to see if we can intervene. 100% of the time, with a little bit of effort, we can save one another. Thank you so much for that comment, because it's right on point. And
I agree with you, Dr.
That is constant. It is constant. It is not moving. If we're talking about women primarily today. Women have much more stressors. I don't care what strata the woman is. We have much more stressors than you men in this society. We do a lot for you guys. With the neck that moves that head. Look at me. Okay. So, Dr. Michael, yourself, Papa Mike.
Tell him, sister, tell him. Tell all of them.
Papa Mike, come on, sir.
Okay.
Yes, sir.
First of all, I want to thank Dr. Famuyiwa for that presentation and the depth, the clarity of explaining things, everything. God bless you. You have spoken about this stress and so on, and what is happening to particularly female doctors. I want to suggest that both men and women pass through a lot of stress that may not be necessary, and that there should be a balance. And there's one thing that helps me in my work. I'm fairly busy as a person, but I don't allow the stress to come in to press me down. And one thing policy I have had, which may help other people, is I am a helper. I am not a redeemer. I am a helper. I am not a redeemer. A redeemer dies in the process of helping. A helper helps on, and when he sees that he is stressed, he stops so that he may help again tomorrow. I don't know whether it makes sense. That means if I listen to my body and I know that I am undergoing what is not necessary, I stop and check myself. And Dr. Ajagbe mentioned one thing, sleep. If we don't have enough sleep each 24 hours, and we are committed to whatever we are doing, we are not doing ourselves or even the patients any good. So we must find time to rest enough so that we may continue to help other people more and more for a longer time. The second thing I want to mention is, in my own field, the use of appropriate herbs to help pregnant women at different times of the pregnancy. There are herbs that help the first 3 months of pregnancy to be retained, and they are mainly hormonal in nature. there are auxins in plants that will help that pregnancy to remain. There are also herbs that help the last 3 months to be easy for delivery. Incidentally, there are even herbs that contain the two extremes. Those that will prevent, what is it? I don't want
pregnancy loss.
Yeah, pregnancy loss.
Miscarriage. Yeah?
Miscarriage, thank you very much. And there are those that will allow the pregnancy to
thrive.
Exactly. And I think a lot of research has to be done into this so that our people at the local level in Africa can be helped. And I want to mention one book. If any of us who are doing research can get that book and use it as a compendium for research, and it is The Useful Plants of Tropical West Africa. The Useful Plants of Tropical West Africa. There are 6 volumes, and each of the volumes is bigger than 2 Bibles combined together. Most of the plants in the tropical world are inside those volumes, with a lot of research done on every plant from local indigenous knowledge. The editor is Burkill, Burkill. Burkill. I came across one volume of that book when I was a high school level student in 1959, and I started studying that book and got the 5 volumes later on, and I've been studying those books since 1959 to date. All my research have come mainly from those books. Africa must make use of those books for advancement in medicine, in treatment, and in everything. Thank you.
Wow. Thank you so much, sir. Much appreciated, sir. I wrote the book, the name of the book and the author in the chat box for anyone interested. And for us doctors on this forum, or everyone in medical field, dentists and all, I think we need to remember that we are helpers and not redeemers. We need to give time for ourselves. We need to take care of ourselves so that we can continue to be useful to others. There was a question on the forum, Dr. Famuyiwa, by Dr. Ephraim. He says, thanks. Okay, how much time is ideal for maternity leave?
Oh gosh, that's a loaded question.
Because you were talking about, women in medicine not getting enough time for maternity and stuff like that was when that question.
I don't know that I'm qualified to do that, to give that answer. I think it's an individual thing, and also certainly depends on how much help you have, right? Versus no help at all. I'm going to defer on that question.
I'll give it a stab.
Yeah.
I think every woman should have at least 3 months to 6 months of maternity leave.
If they can get it.
It's a general question to say, if you want to set a standard for what women should have, at least 3 to 6 months. I would say 6 months. Because if you think about it, breastfeeding, when does baby start eating, other food products? It's at 4 months that you add, other food products to what babies eat apart from breast milk. And you're right, it depends on what kind of help one has. But an employer, that's not an employer's business to know what help a woman has or not have. But if standard were to be set, that's what I would say. So that being said,
Dr. O,
yes,
there's also financial component for some people, because when you're on maternity leave, you could take a year, you could take a whole year. The employer is obligated to keep your position, but can you afford it financially? So if you're thinking to take 6 months, you need to save up way before then, because you don't get a full paycheck because you'll be on disability and the COBRA that you have to be paying out of pocket. You need all the medical help. I think that's one of those crucial components that, you know, it drives people to go back to work sooner than they really would have wanted to.
Yes, because most employers will give a certain amount of time that is paid, but after that, you can take the time is not paid. That's true.
Catch 22.
Catch 22, yeah. So, Sister Lola, go ahead.
Yes, I
She
agree
agrees with
you.
me, by the way, 3 months to 6 months. Go ahead.
I agree with you. Like in Germany and most European countries, they give you 6 months and with pay by the government too.
Yeah, and you know,
and it doesn't matter what your profession is.
Well, those are the places also where you're allowed to take a siesta. You take a nap during the day. We don't do that here. I think America is the most hardworking country in the world. God knows that. I'm telling you. If you look at, how people work here, the work ethic and all, it's amazing. So I want to share this, that, we have a huge thing going on in our country today. And if we don't talk about it when we're talking about this subject, then it means that we're tiptoeing around what is important and not actually, and not addressing it. Roe versus Wade. Next week, we'll see what happens. We may bring on the forum people with different views to talk more about this. But I think it needs to be broached even today because we're talking about this subject. The issue of abortion is huge. Miscarriage and pregnancy loss is what we're talking about. We talked about today. That is something that happens that is not pre-planned or not wanted. Pregnancies that are wanted that then get lost for whatever reason is not a situation that is welcomed. I have had in one of my losses, one really kicked my behind the most, where I got up in the morning to use the bathroom, and what came out was the fetus that I picked up in my hand, and that was hard. Even though I've seen it in the emergency room, I've seen it in other women. When it came to me, it wasn't the same. And that's how most of us feel in this profession. When it comes to you, it's just not the same. So when it comes to abortion is never a good thing. I've seen a lot of people who have had abortions and then they have the residual depression, anxiety, and and all whatnot. So but things happen to people. What about in the case of rape? Is it allowed? Is it something that should be that one should sympathize with if the raped person decides to abort the fetus? I have seen where the baby is born and the mother who went through this trauma loved their baby and raised this child. One that I know, the girl, it was a girl, became a physician, taking care of the mother. Can women be encouraged to have babies like that and give them up for adoption if they cannot take care of them? What about in the case of, Dr. Famuyiwa can talk about this, where ultrasound is done and they see that the baby would have deformity of some sort. I have seen that happen, and baby is born and the baby is perfectly fine and doesn't have Down syndrome or what has been said they could have had. But some babies actually came out and they have problems, they have issues. I think these things need to be discussed. I don't think it's clear cut, simple. I think personally, because I'm not scared to take a stand, I believe the woman's body is the woman's, and the woman should be allowed to make their decision as to what they want to do with their body. That's what I believe. Whether I agree with abortion or not, I think is immaterial when it comes to somebody else. For me, I think I should be allowed to make that decision for me. But it is not my place to make that decision for Dr. Famuyiwa. She should make her own decision based on her life, her beliefs, and what she chooses. And I say that because I love Jesus as my Lord and Savior. And I believe Jesus Christ, it's not believe. I know for a fact that Jesus Christ gives us a choice. He presented himself. He still does every day. He lets you know who he is, and that is the way, the truth, and the life. No man comes to the Father but through him. But you have a choice. You can decide to serve Christ or not serve Christ. That's choice. And so my take, but we'll see what we do with this in the future. I don't think it's a subject we should run away from. If you think we should run away from it, private chat me. If you think we should discuss it, private chat me or chat me openly. Madam CEO, go ahead, ma. You have your hand raised. Go ahead, ma.
Yeah, thank you, Doctor. I stand with you 100% because it's not even, it's a polarized issue without a doubt. It's very political. It's not, they're not even, I don't even think that these people care about the abortion. It's about the autonomy. I should be able to make the decision that is best for me. You mentioned two critical cases. In the case of rape, in the case of medical issue, like a 45-year-old person who is now going to be having a deformed baby. Caring for a baby like that is very stressful. You don't have a life anymore. And that baby pretty much doesn't really have a quality life. So that decision is a family. You should reside with the family to let the family do that. They should not demonize people that have that option. As a Christian, I don't support abortion. And as a woman, I am pro-choice. I should be able to, any more than I have the right to tell all the men that they should go and nuke themselves. Because it takes two to have pregnancy, right?
Yeah.
So if you don't want the girl to be pregnant, then let all the men go and get, what is it they have to do? To
vasectomy.
Right? Yes, that's right. I think that maybe Dr. Attorney Tolu will help us to do that class action. We need to mandate that all men go and get vasectomy. That's the only way to prevent. That's the only way to prevent unwanted pregnancy. So it's about taking away our autonomy, and this affects mostly minority. So what's next? What's next? It's a slippery slope. So yeah, we should take a stand, but at the end of the day, that decision is individualized, and they're taking that away. It's part of our right, freedom of speech, freedom to make the decision who I associate with, who I speak with, what I eat. They're taking that away from women. We're almost back to the Stone Age, and it's not right. Thank you.
Thank you so much. Thank you. Geez, I feel your passion. Brother Taye Doherty said, that is talking like an American. So our pastor and attorney, Bamidele Onigbide, kindly unmute, sir. Go ahead.
I hope I raised my hand.
Yes, you did. But I wanted to give him a chance because he has not spoken tonight. I'll call on you right after.
I just want to, I think there's a way we can broach this and scratch it. And
next week.
There's also a way we can dig deep into it. But I also want us to understand how sensitive this is. Mm-hmm. And if you actually want to open it up, I want you to be ready to receive all kind of perspectives. Now, the problem with perspective is not that it's wrong. The problem is when you have multiple people who say, well, from my perspective, this is it, and I am right. And the other person said, from my perspective, this is it, and I am right. Now you have collision of rights, and there will be tension. And so I think we need to prepare ourselves to handle this with all kind of sensitivity and also a readiness to listen to things that we have not thought about. I mean, I take on these in the church, and I have, Caucasian women who, look, people think it's political. It's not. People think it's physical. People think it's personal. Some think it's woman. And I believe it is spiritual. That's what I believe. Because if you say, okay, it's personal, what makes you make your decision? What makes you do this or do that? And everything else. But look, at the end of the day, I believe that when we think about, the definitions, when you approach it from definitions, the definition of what a fetus is, the definition of whether it's a viable life, the definition of whether a woman is actually pregnant when they think they're pregnant, the definition of this or that, it's going to open up, everybody think, just bringing to bear what they think, anything. I mean, some people believe that a fetus is not viable until 3 trimester or first. I mean, I don't know much about it, but at the end of the day, some people will say, well, as soon as that child is conceived in your womb, you may not even know when. The woman don't even know when. I mean, I guarantee the woman, you don't even know exactly when the child is conceived. The good doctor Famuyiwa tries to show us a video of something going on. They show the video of swimming sperm going from this, and it takes, I think she told us it takes 3 days or so. 3 days, I don't know.
5 days.
5 days. The woman is going about, going on the run in the clinic and the hospital ward, and he doesn't even know there's a journey going on, even in her womb. And until when, she is vomiting or all that. And God is like, okay, you know what? You don't even know when the child is conceived, but I want you to know that before the child is even conceived in your womb, I know him. That's deep. Some people will say, what are you talking about? Knowing the child before it's conceived, and who is going to make a definition? What is the definition of that? So, and that is the reason why I think we need to. I agree with Dr. O. We need to take on this. It's a current affair. It's a current subject. In our church, I told the women, everybody's ears were stretched, but I told them, I said, listen to me. I don't want abortion. I don't like abortion. But I want you to understand that 1 million Supreme Court justices can't stop a sinner or can't stop anyone from doing whatever they want. Now they're going to Canada. What are you going to do about it? Now they go to Mexico. What are you going to do about it? So in other words, it's not about legislation. It's not about rewriting settled laws or settled decision or ruling of the habeas court. It's about, appealing to the heart of man. Or maybe we can say the heart of woman too. Look, that when you have to make that decision, that God is present in it. So that, it's not that you're just saying, well, this is my body. If you say this is my body, it doesn't stop there. Then we need to say, we'll give you the body.
You know what?
Yeah.
You're going to be on the panel next week.
Okay, I'm going to be quiet.
No, you're going to be on the panel next week.
No.
Madam CEO will be on the panel next week. So hold the thought, because you know what? Like you said, I've said it before, I'm going to bring people with diverse opinions on this.
That's why this platform is great.
Yes,
you
and
know.
you know that that's what we do all the time. We all agree. Remember when we come on this platform.
But Dr.
You are looking at the spiritual.
Yeah. No, I want you to. Yes, sir. Yes, ma'am. I want you to I want to prepare people, and I believe that will help us. This is a subject like no other. And I know we have taken on all kinds of subjects, but I want people not to go away fighting.
No, it won't. No, don't worry about it.
Yeah. So,
emotions will still be stirred.
Yeah.
Like it's stirred. You don't look, sometimes after Medical Mondays, I had to deal with some things. Yeah, because you know, people still need clarification here, emotions and it will happen. And that's what builds us. We need it. We need this conversation. I don't believe we need to continue to hide and run under something. Something is going on, we won't discuss it. It affects us. I want to look at the medical aspect, the mental health aspect of this, the medical side of this. When, you know, the decision that is made, let me explain something to you. People will start doing abortion themselves. They will start using things. I'm not going to say
God help
us. I don't want to put ideas into people's heads.
Yeah.
But, you know, there may be other things that could occur that may endanger people's lives.
Yeah.
So, Dr. Famuyiwa may have to leave now. If you have any questions for her, please ask. Otherwise, forever hold your peace.
Thank you so much.
Thank you so very much. We are grateful. We're very grateful for your contribution. God bless you. Be here next week, because an important subject, Roe versus Wade. I can see you shrinking, you know, not wanting. Please be here. If you're not participating, come listen. It's an issue we need to discuss. I'm not one to go out and start parading and you know, breaking down something or protest. No, apart from Black Lives Matter, I think is the only protest I've ever been in, because Black lives do matter. But it wasn't really a protest. It was just a gathering to talk about this issue in DC. Apart from that, you know, but I think we need to discuss this, so we need to know moving forward. So see you next week. Thank you so much.
Thank you.
I'm going to call on Sister Lola again to give your comment.
Yes, thank you. My only concern, if it has been any other country that this Roe versus Wade has started, probably I won't say much or I won't be concerned. But in a country where the bullets is flying all over the place, and you want to preserve lives, and you're killing lives, you're more concerned about money that you're making from selling guns.
Thank you.
And then you want to start, I can't phantom it, I can't put it together. I'm pro-life and I'm also pro-choice. So I don't know where I'm going to stand in the middle, but I don't get it. You can't preserve life to cop selling guns, but you want people to bring more lives to the world? I don't get
it. You know what? I so much love you, because a lot of us are there. We pro-life. We don't support people. We don't support that people should have abortion. But a woman needs to make her own decision. It's their right to make the decision. It's their body. Madam CEO said it all. What will be next? Because we can sit and be smiling and be, what will be next? When something is forced down your throat, what is the next thing that now will be forced down your throat? This is paving a way. for bigger things. We can't just sit still. Dr. Jagwe, go ahead, sir.
Well, I was just going to make a comment on I didn't know that there would be an idea of having a full discussion about it next week. I was just going to cite my own experience in Howard University while I was teaching in the College of Dentistry as a professor of pathology and oral embryology. This was a question I always asked my sophomore students at that time. I was teaching embryology, and that is the development of fetus. And so the first question I asked on the first day of class is, when does life begin? So when I asked the question, when does life begin, what you are talking about, Dr. Attorney Onigbide, it was letting out, opening the Pandora's box. And everybody will come with their preconceived ideas and biases and everything. So I will give them close to 1 hour to exchange their views. And then I will then intervene and say, okay, well, we're not talking about politics here, neither are we talking about religion, but we're talking about, when do you believe that life begins as a medical student or dental student? And that was always an issue. So the way I broke it down for everybody is to I asked simple questions. They were not rhetorical questions, but they were questions that you don't need to be a rocket scientist to figure it out. The first question I'll ask them is, can two dead people make a baby? The answer is no. Can one live person and a dead person make a baby? The answer will still be no. All right? But can you take samples from a dead man, like sperm, and a sample from a dead woman, the egg, and fertilize in the test tube? The answer will still be no. So it shows to me, in a simple term, that life is continuous. Life transcends the stages of life that we encounter. And the reason is, life goes from one generation to the other. It is not stopping at any point in time. It keeps going on. It is a sperm or spermatozoa and an ovum. They are half cells. They must come from living individual, whether you harvest it or they transmit it from one to the other in physical form. They must be live. So the life is transcending, is moving from one generation to the next. So by the time you look at it, then you know life is not just starting at fertilization. No. Life continues from one half cell and half cell coming together into the next identity. So what starts at fertilization is the identity of an individual just being formed. That individual will be unique among all others. And so that is what begins at fertilization. And then we will start looking at it. Okay, if after fertilization, somebody zaps that fertilized, what we now call embryo, zaps it with radiation, and that embryo stops dividing. It means the life of that embryo is gone. So now we see that life, unless it's abruptly halted, does not stop. It continues to go on. If something happens like we talked about today, Dr. Famuyiwa was talking about all the factors affecting spontaneous abortion, miscarriages, as we call them. Those were opportunities for life to start. The identity of those individuals that were formed at fertilization to stop. It cannot go on to next generation. So by the time we figure it out and see that every step of the way, from sperm and egg to embryo to fetus, there is no stoppage of life. Life is continuous. So you can't tell me like, oh, the life starts only when the heart starts beating in a fetus. Like some people will argue, oh, life doesn't start until the baby is born. I mean, or life, I think we must separate the biological aspect from the political aspect. The reason is this: the American Congress or the lawmakers are looking at the aspect of it, saying that who has a right? Does a fetus that doesn't have an identity recorded by a social security agency, does that count as an individual? Is that person an individual? Those are the nitty-gritty of the discussion. It's not so much about whether a child is alive or not in the womb. We know the child is alive. That's why people will lay their hands on the pregnant tummy and they feel the baby moving, they feel the leg pushing, they feel elbow pushing. All of these things just support the fact that there is a life developing in the woman's womb. However, the aspect of the politics of whether somebody has a right or not, doesn't have a right, that is totally away from the objective, determination of who is alive. An embryo which is only 1 hour old or 2 days old is as alive as an embryo that is about 9 months old. Thank you for letting me share that.
Thank you, sir. Thank you very much. Yeah, Dr. Famuyiwa, I did already. I apologize on your behalf that, if anybody has any questions for you, they should ask. Nobody did.
Okay,
So
thank you.
yeah, I did.
Thank you. I appreciate it. Thank you for a lovely session. Thank you.
Thank you. Much appreciated. Dr. Jagbe, thank you so much for that expansion and elaboration. I think we will tackle this next week. But in the forum, Maroon brother, Mr. Taye Doherty, stated that should the state pay for abortion, though? And my take on that is that the state should not pay for abortion. Individuals who want to have abortion should pay for their abortion. In fact, I don't think taxpayers' money should be used for abortion. Again, these are my opinions. Next week, the panel will tackle things like this. I'm going to write that question down. So, and it says that is some people's argument against abortion, not the woman making decision on their own body. And I wrote something there that I don't think the state should pay for abortion, as I do not think, which is only a comparison, Dr. Craig, that I do not think the state should pay for pre-op exams, for cosmetic surgeries, or for liposuction, which is happening today. Those are taxpayers' money. I think you should do lifestyle changes to decrease your abdominal fat or to lose weight. Taxpayers' money should not be spent in any way to assist with that, or to do breast job of some sort, unless it's medical with breast reduction. That is different when it's medical. So that's what I'm saying. So you might have misread that. I was comparing. To me, it seems the same. That states should not be paying for that. So Attorney Akinshola says that is why she cannot wrap her head around it when it's okay to murder a live individual with a gun. No assistance is coming from that arena. It depends on the circumstances surrounding the abortion decision. And you know what? That is a discussion we're going to have. It is very important. Madam CEO, you raised your hand at some point. Professor Baba, You're coming on the panel next week because we want to hear your social aspect. He said, I agree with Dr. 100%. Thank you. The state should not pay lifestyle. They shouldn't. So next week we will discuss this. I think it is important. I have stated my opinions. My opinions do not have to be right. It's a discussion we need to have so that then we know moving forward what to do. My understanding also is that the Supreme Court's decision is that now each state will decide if they would allow abortion or not. Am I right or wrong? Is that true? I was in Nigeria when this was going on. Is that correct? Does somebody know? That
Yes.
states will make a decision. Okay.
You're correct.
So I think that's a fair thing to do. And sir, if somebody goes from the state of, goes from Florida, because I think Florida is going to ban abortion, or Texas, and they maybe come to Maryland to come have abortion, you bet they're going to pay out of their pocket because they don't have the Maryland state insurance. Maybe that also would cause people to think twice. But there's a lot to discuss here. And the Lord
Doctor, we know those states that will be banning the abortion. We know.
we do.
We know them.
We do. But, you know, it cannot end here. We have to discuss it. And we have to make our opinions known to the authorities that matter. It's very important. Any other comments?
Well, I don't know what, hello?
Yeah, go ahead.
I don't know what has been discussed. I came in late, so I do apologize, and I don't want to take you back. However, I believe that God said we should multiply. He said he has provided everything for us. I would say all of us are guilty. Pro-life, that's what we should be. However, why are we using contraceptives in the first place? We should be multiplying. That's why he said, if we're going to be really religious about it, all of us are guilty. It's just that somebody got caught and the other one didn't get caught. Okay, so what I'm saying is when you look at it, I don't believe anybody should pass judgment on what a woman should do with her body, because there are so many aspects we have to look at. For you to be able to carry a child, you must be psychologically and emotionally ready to do it. And so if that is not there, then this is where we have cases of abuse. This is where we have cases of abuse and neglect, which is already common in the society. Now we are now going to tell somebody to make a decision about what happens to the child she's carrying, or we are going to force our decision on that person. Also, I think it's an insult on women when you are telling them what to do with their body, because both men and women are responsible. So why does the woman have to deal with this alone? Now, what about in cases of rape, child incest? Do they have resources? If you tell a woman not to have abortion, does the state have resources to take care of this child? In case the child, for example, if the parents are not financially able, they want to have an education, they want to do other things, and this child comes up and they know they definitely cannot afford it in their situation. Does the state have resources to support the parents financially? They don't have that. If they don't have all those resources that we are talking about, why meddle with the matter? So I would suggest that they should let the woman have the right to make a decision about what she wants to do, because it's her body. And men also, it should be dual responsibility. So that's my opinion on this subject.
Thank you so much. It's a charged subject. Thank you. Sister Tinu says, even if the states do have resources for a very sensitive person, she will forever think about the baby that she is forced to have. It's a hard topic, as Dr. Cap said.
You know,
So,
Dr. O,
yes, sir.
you know, the strange thing about it is, unless we have the political will and the influence where the decisions are made, all of our opinions carry no weight.
Well, Dr. Jagbe,
Unless we can influence this decision at the level where it matters. So whether we're going to be running for offices or we're going to have such a big advocacy in whichever direction we think is right, it will just be noise, because 300 million people in America, if everybody's opinion is important in some way or another.
Thank you, sir. But I do beg to disagree. For one thing, we have doors we can knock and penetrate. Sister Tinu, am I right? You can, it could take a while to penetrate doors, but we can if we have to. But the purpose of our conversation is very important, because this is a mental health issue. This is we don't know each person's personal issues. We don't know where people have been. We don't know what people are dealing with. So in discussion, people may find what they need, or be able to have connection to some of us that may be able to lend a hand to their situation.
Absolutely. Be informed and be involved.
Thank you.
You come here to get information and you choose what direction you're going to go. It's about information.
Thank you, ma'am.
Let's go.
That's it. Straight to the point. Thank you, ma. So next week we'll have the discussion. It's very, very important. Sister Tinu also wrote, we have the data out there that says 56% of people are opposed to the decision versus 40% that support the decision. That's 4 steps. Dr. Craig says, is dismayed in the final analysis at the need to discuss whether a woman should have control of her body. Dr. Fawale says, awareness is the beginning of change. We have hope. And I agree. The discussion brings awareness. Sister Tinu wrote again that all men, with the exception of a female who intends to have 7 children, making decisions for women. All men, with the exception of a female who intends to have 7 children, making decisions for women. Preposterous. Well, by God's grace, next week we will have this discussion. We'll have a panel, and it is important for our own well-being, at least to know where to get some, it would help. Dr. Jagbe, stay tuned, coming next week, all the way from Nigeria, and you will see how beneficial it will be. So I want to wind down and round up for today. A big thank you to Dr. Famuyiwa. This was an awesome conversation. Thank you all men on this platform who showed up tonight, because some men did not show up because they think, oh, what am I doing with pregnancy? But pregnancy losses, Roe versus Wade affects everybody. If it's not your wife anymore, you have daughters, you have granddaughters, and knowledge is power. The knowledge we attain, we can use, to assist family members, even friends. We have friends that are female. So thank you so much. I raise my hat to every man who participated in this discussion tonight, and look forward to seeing you next week for also that important discussion on Roe versus Wade. Again, we meet to have these conversations, not to establish patient-physician relationships, but to attain and gain knowledge. And so till we meet next week, please stay safe and be blessed. Have a good night.
Thank you.
Thank you.